Hello and welcome back to the Out of Program podcast. So today we're joined by Dr. Benjamin Viaris de Lizenio, a women's health consultant and health tech entrepreneur with a career spanning both France and the UK. He is the co-founder of Cellen, a pioneering platform for personalised medicine, and Leva Clinic, one of the UK's first digital pain clinics. Welcome to the show.
Thank you, Jean. Thank you very much for having me. It's an honor.
Oh, you're too kind. So let's start from the beginning then. What got you into medicine?
I come from a long dynasty of doctors. My grandfather was a doctor. His grandfather was a doctor. His grandfather actually worked with Pasteur in France, developing one of the first vaccines. It's been a long time, and I think there was this unspoken pressure in my family to be a doctor. And actually I embraced it very, very early. I think I decided I was going to be a doctor from the age of 3 or 4. And I was like, I'm going to be a doctor. I'm going to be a doctor. And I ended up a doctor.
I definitely know that feeling of that subtle, unsaid pressure. And you were a medical student in France. Can you talk to me about that?
Absolutely. So I'm French, as my name has given away already. So I was living in Paris, studied medical school in Paris. I think very, very simply, I went from high school to medical school, my local medical school in the south of Paris. It was something that came very naturally, passed the exams. It was at the time where there was a very important funnel. I think in my year, between the first year and the second year, they took less than 6% of students passed from first year to second year, because in France there's a big funnel at the end of first year. And I had wonderful years as a med student in Paris. I was very lucky to be able to go into tertiary centers and work a little bit everywhere. It was fantastic, really.
And medical school in France, is it more academic or is it quite practical?
Medical school in France, compared to the UK, is much more practical. So the first 3 years is full-time at the university, and the 3 after that is every morning at the hospital, every afternoon at the university. And so by the time you're done with medical school, you usually have the level of an F2 or an ST1 in the UK, because actually you just do clinical work every morning from 7 to 1 or 2. And then you go to the university and you start your classes at 2 and you finish at 7. So those are very long days, but you do a lot more clinical work than in the UK. And when I see the med students in my trust right now, they show up at 9 and at 12 they leave, and they actually do very little. They are on their tablet, making sure that what you're talking about fits with their classes. It's very different. Like the one thing is that med students in the UK do not have any clinical responsibility. If they were not here, it wouldn't change the care to patients, which is not the case in France. You have clinical responsibilities. If the med student doesn't show up, or if a med student is sick, then the matron has to hire a locum nurse or a locum ST1 to cover for their clinical responsibilities. And because you have those responsibilities, you actually get into the nitty-gritty of clinical life much more. And that's why we don't have foundation years in France. It's because while you're a med student, you do all the things that a foundation year would do in the UK. So you move directly from the end of medical school into ST1.
So there's a high attrition rate, it's highly vocational, and the hours sound pretty long. But you said you quite enjoyed that.
I loved it. I was very lucky. As you said, it's a vocation, and it's a calling that I had very early. So it was difficult and painful, and at many moments I thought I was gonna just send it flying and just stop and slammed the door on my way out, but actually I stayed, and I'm here.
And during your time as a medical student, did you pursue any, off the beaten path kind of opportunities?
I think I didn't have any time. I really didn't have enough time to be able to spend any energy on anything but studying. I was very lucky that I was financially supported by my family, but not enough so that I could not have to work. And so I worked as a nurse on the weekends, in the evenings, or at night. I was a telephone operator for the emergency, doing triage over the phone. I was a psychiatric nurse at night or on the weekend. I did a lot of different things, and so I didn't have enough time to do anything else.
Wow, it sounds like you were completely immersed within clinical practice. Were other French students pursuing different things? Like, what was the culture like in terms of exploring different opportunities?
There is no culture for technical bridges and extrapolation of certain skills from one specialty or one industry into another in the UK, in France compared to the UK. In the UK, I see many people who were med students, never became junior doctors, never became trainees, and jumped into finance, into biology PhDs, into consultancy, lots of different things. That did not exist at all when I was a med student. So if you decided that you were going to stop being a med student somewhere during your training, then you could have applied for biology in some way and tried to negotiate at the time, because it was not formalized, that some of your semesters as a med student would validate some of your semesters in biology or in whatever field of science and bioengineering or anything like that. But nothing formalized existed, and it is not really recognized in the French culture that all the skills that you built during medical school are skills that you can apply to another industry. And that actually is a reflection on a lot of the things we're going to talk about my junior years, about my path all the way to CCT being a consultant.
And you just mentioned your junior years. So did you spend those in France in clinical training?
So I was a specialist trainee in Obs and Gynae in France, but not in Paris anymore. I went to Normandy, which was now is very close and dear to my heart, but I did not know at the time. And I did my all of my years as a sub-spec trainee and spec trainee and sub-spec trainee in Normandy.
So when did you start getting involved in the startup scene? Because to my understanding, you started off in France. Is that right?
Absolutely. The training was so brutal. When I see how easy it is for trainee right now, I sometimes roll my eyes when they're complaining about the hours. I belong to the generation of people who said, well, all of that didn't exist. We would be on call for 72 hours from Friday morning to Monday morning, and that was normal and no one complained about it. And if you slept, then you slept. If you didn't sleep, then you didn't sleep, and that was what it is. So yeah, I come from a generation of people where there was no pre-night shift rest and post-night shift rest. So my night shift was Monday night. So I would show up at the hospital at 7 in the morning on Monday morning. I would do my clinical activities and duties for Monday morning. Then I would do my night shift duty for Monday night. And then when the night shift was finished, I had a clinical activities on the Tuesday, which I would do until I finish. Usually I would move all the non-essentials outside of my Tuesday. So I would finish my Tuesday around 2 p.m. And so you would be at the hospital. You would have had a couple of hours of sleep on a Monday, during the night on Monday. And it was pre all of the research with regards to burnout, with regards to clinical errors post-night shifts. Like, I vividly remember when I was in ST5, the first study being published and everybody talking about it. Well, we all somehow knew that once you were at your 35th hour of shift, you were less efficient. But it was not quantified, the level of medical errors that you were making, and therefore there was no responsibility. And so I remember the studies in my university happening where they would make you psychometric tests and reflex tests and manipulation tests at the beginning at like 6:30 in the morning on Monday. They would make you do them at the end of the day at 7 p.m. on a Monday, and then they would do it again on the Tuesday morning, and then again on the Tuesday evening. And you can clearly show that your brain is suffering over the course of those 48 hours. But it didn't exist. And then suddenly there was a change in the regulation, and the European Working Time Directive was implemented. And when that was implemented, France decided to opt out of it. So every year, France pays a fine to the European Union because they opted out for the healthcare system only of the European Time Directive. And so there is still no time restrictions on doctors' practice. So when I arrived in the UK, my first contract was a time-bound contract. You are paid for 10 PAs. Those 10 PAs are distributed across all of those activities and duties. In France, it's the other way around. You are paid for X amount of activities and duties, and the amount of time that it takes you to do all of those activities is your own problem. So you're responsible for the ward. You have to do the ward round in the morning. You have to do the post-ward round at the end of the day. But if there's 2 people in the ward round in the ward and it takes you half a day and you leave early, great. If there's 25 people and it takes you until 11 at night, then it doesn't matter because this is not the way your contract is set. And so the concept of extra hours or people doing locums to cover clinical activities did not exist. And to give you a really clear example, we had 12 trainees in the unit. 3 of them went onto maternity leave at the same time. We just distributed all of their clinical activities across the 10 other ones. So everyone had a 30% increase in their, or 25% increase in their clinical activities. No one got paid extra hours. No one was paid locums. All of that didn't exist, and I believe is starting to be implemented, but it's not the way people think about it in France.
Wow. I mean, have you thought about giving NHS England a call? I mean, there's a big workforce productivity problem. Sounds like you've got the answer right here.
It's one of the reasons why the French system is a little bit more efficient than the English one. One of the reasons why the French system is more liked by patients, because when you are set up as a responsibility first and duty first workforce and not as a time-bound workforce, you actually internalize that in a very different way. And so it's not that I do my shift and then somebody else is going to cover. It's that those are my patients. And when I'm not there, I'm lucky that someone cares for them, but they're still my patients. And actually, it creates a very different mindset.
So it sounds like life as a trainee is pretty brutal, putting it euphemistically.
I would compare the trainee in France as the trainee in the US. Yes, it's that kind of brutal training.
But then how did you carve out the time then to explore the startup scene in France whilst you were a trainee?
Mental health. It's just mental health. I was so burnt out that I found the thing that deep inside of me was driving me. And I realized that I had this inkling for entrepreneurship. I had this itching for working on innovation and tech. I really, really loved it. And so when I was not on shift, when I was post-shift, when I was in between clinical activities, I was looking for people who were thinking like me. And at the time, there was nothing. When I started investing time into the health tech scene, first of all, the word health tech was not coined. It didn't exist. We were still talking about health IT. That's the way you talked about it. You said, oh, like I have this project in IT. And people were like, oh, you repair computers. I'm like, no. I'm trying to create an algorithm or a chat bot for this or that. It didn't exist. The ecosystem and the industry didn't exist at all. To give you an idea, there was no dedicated VC or accelerator anywhere in Europe. There was no dedicated funding. If you talked to VC, even big VCs, they didn't have a vertical that existed for health at the time. And so, well, for certain types of health, like private health, yes, but not for health tech or med tech or biotech or any of those. And so they had pharma or they have private health, where they were building private hospitals. But that was pretty much it. And so at the time, I saw a format which was a form of hackathon, which was and is still called a startup weekend. And my brother was actually quite big in the startup weekend scene across the world. And I was on a humanitarian mission in Syria during the war.
Wow.
And my brother calls me and he's like, "Oh, I'm in Bethlehem hosting a startup weekend / hackathon for 3 days. You're not too far. Do you wanna come?" And I'm like, "Yeah, why not?" And so I'm take my backpack, and then I went to see him, and I had an incredible time. I had so much fun. I'm like, this is the format that we need within the French National Health System. And so I then imported that format. And the reason why a hackathon was not something that was appealing to a doctor, and the reason why a startup weekend is because a hackathon is all about the tech. And the problem in health tech is never the tech. The tech exists. That's not, creating the tech is not a problem. The problem is creating a sensible path to data to generate the requirements, demonstrate that it's clinically viable, that you have, that you reach the clinical outcome that you want to, so that you can get your, I don't know, medical device classification, so that you can get your recognition here and there. All of the regulatory path is a big hurdle, not the tech. And the second big hurdle is funding. How are you going to fund it? Who are you going to see? Do you go for grant money? Do you go for VC money? Do you go all of that? And so a hackathon, actually building a little bit of tech, it's actually misleading because it gives young doctors or young health tech inspired people the illusion that, well, you can do it. But actually that's not where the difficulty is. And you know that yourself. And
yeah,
so,
for sure.
Exactly. And so I tweaked the model of the Startup Weekend, who had a lot of emphasis on team, on funding, on all of that, not the tech. And I added a regulatory layer. What is the regulatory pathway that you have to go through to be able to validate that technology and create clinically responsible tools? And then I created and I organized first events within the French National Health System. It was the first quote-unquote hackathon within the French National Health System ever organized. Created a community around that and continued to advise and support companies who won across those different events. And that's how I became an advisor and then a clinical strategist and then board member and things like that.
Wow, so it all started from taking the concept that you saw in, when you were on humanitarian duty, in Bethlehem, across to France. And were you the only one doing this at the time? Were there other pockets?
So there were other pockets, definitely. I think in the Paris area there was 4 or 5 individual groups that spawned spontaneously because I was not the only geek working in health. And there was, but I always found that the other groups were much more focused on tech, and that was the USP of the community that I created. It was that we know that the tech exists, we know that the tech is feasible. We've seen the tech in many other aspects. The problem is not the tech, and I really think at the core that's what you need to look at when you're very early on in a health tech journey. I think the tech is important, is very important, but it's not the most likely reason why you're going to fail. The most likely reason why you're going to fail is either funding or regulatory.
So at this point, you're working in a really intense trainee job. You've brought this concept of startup hackathons that you've tweaked based on what you saw as part of the market, and it sounds like it's going great. I think most people in that situation would think, how do I pursue this path in France and become the clinical director of innovation for the whole of France? But you actually then moved to the UK at some point. So what kind of prompted that move?
So first of all, I moved for love. My wife's American. She came to Paris. She tried to find a job with the career that worked for her, but it didn't. And then we decided that London was the right place for both of us. But by that time, I was already a consultant, and I was already involved in a lot of the tech scene in France. But what's really interesting is one step before that is the decision to go all the way to CCT and not just stop in the middle of my training. I think we see in the UK currently a lot of junior doctors who have one foot in health tech or are starting to put a foot in health tech or already have an entire leg into health tech and who are like just stopping before their CCT. And they're like,
Yes.
okay, I've specialized. I've done 3-4 years into training. I'm an ST something, and I feel like clinical work is not for me. I want to jump head first into health tech. And first of all, because the industry was so nascent in France, it was unheard of. No one had ever done that, left in the middle of training. The second thing is because there was no official bridge, if you stopped your training, no one was sure that you could come back to the same ST position 3 years later. It was possible that the dean of the university said, well, you left, you're done, or you're starting from ST1 or something like that. Nobody really knew. And if you didn't get your CCT and you didn't become a consultant, you would always be someone who only had an MBBS. And I didn't want that for myself. I wanted to make sure that I secured a backup plan and I secured credentials, because now everywhere I go, I'm a consultant. And that creates a lot of momentum, a lot more momentum, especially if you're trying to sell a platform to another consultant. And if you're only an MBBS, they're like, oh, he's a med student, he knows a little bit about medicine.
Yeah.
When you're a consultant, you've seen tens of thousands of patients in consultation. You've done tens of thousands of hours of surgery. When you talk to a consultant, it's a very different conversation. And so actually, in retrospect, it was the right choice to say, okay, I'm going to jump completely into health tech only once I'm a consultant and only once I've practiced as a consultant, because it gave me a much deeper understanding. And one of the things that are usually overlooked by more junior people within the health tech space is, again, that understanding the pathology is not everything. Because when you are a med student, you understand physiology. When you're a specialist trainee, you understand pathology. Once you become a consultant, what you understand is all of the meta elements that are shaping healthcare. Policy, governance, politics, all of those things. And as a consultant in obstetrics and gynecology, I started to understand the intricacies of the relationships between the Department of Health, the French National College, the WHO, the International College of Obstetrics, the International Society of Obstetrics and Gynecology, and you understand all of those dynamics much, much, much better. And you understand the relative positions of all the KOL within the industry. You understand all of those things which you do not grasp at all when you're a junior doctor and when you're a specialist trainee, because you're so focused on understanding the pathology, on narrowing and on sharpening your surgical skills, on all of those little things that you have to learn at that time. And so actually, I have seen many health tech startups fail because their chief medical officer was someone who was a former med student or a former medical trainee who actually did not grasp all of those politics and dynamics that shape your entire specialty, and therefore funding, and therefore regulatory, and therefore all of those aspects. And so I realized much later on when I created my first company that actually having been a consultant had gave me a much better understanding of those things.
I think you touch upon a really great point and a source of much debate amongst the community. of when best to leave the system. And a lot of guests that come onto this show will talk about motivations for leaving healthcare and doing it for the right reasons. Because, in the current climate, there are many that are looking to jump ship, but maybe not because of a pull factor, more of a push factor. Well, and the debate is always, well, can you stick it out a few more years to get to CCT rather than leaving at this kind of middle point or at this junior point? I would say that there are certainly examples of people, myself included, that left quite early on in their career, but it all depends on what you're trying to do. The company that I'm involved with is a workforce system. So, being a junior doctor is arguably enough kind of exposure and experience to understand, how these things work. But when you get deep into startups that are working on clinical pathways or medicines or pharma, then that level of expertise is really important. And, you're absolutely right. There are companies out there where they will have a chief medical officer who is just someone who needed to have a role of this team of 2 or 3. And then they don't have the maybe the authority or the expertise to be able to pull it off for the long run. So I certainly think that the point about getting to CCT is a really pertinent one. I do think that there are some niche examples where that can work out, but broadly, actually completing your training and having that expertise and that authority behind your belt probably serves you very well in the future ventures that you choose to pursue. Only that
I
currently everyone's just so eager to leave. So
I know. There's one data point from a study which I love to quote. It's an Harvard Business Review meta-analysis published, more than 10 years ago now, that looked at the average age of a successful startup. Okay? And what is the path? What makes a successful founder? And what they realize is that besides the fact that, and it's very Western world focused, okay? It's not entirely, it's Western world focused, of course. Besides the fact that usually they are white and male, of course, for good and bad reasons. The other aspect is the fact that they have worked in their industry for more than 15 years. And the average age of a founder of a successful startup is 48 years old. And that spans tens of thousands of startups. It's a huge paper. And it's because the main narrative about a successful founder is Mark Zuckerberg. Everybody thinks about or Steve Jobs, this guy who drops out of college, goes into his garage and create a wonderful tech. That's the narrative. That's not the reality. The reality is in the numbers, is the exact opposite. Someone who's worked in an industry for more than 15 years, someone who is 48 years old, and pretty much exactly that, understands not only the tech, but understands all of those things. I think that is the reason why, for example, in my first company, Leva, which we're going to talk a little bit later on, but it's the reason why the first person I hired as a clinical consultant in my clinic, Leva, was the president of the Pain Society in the UK. You don't end up hiring because you need a pain specialist within your clinic. I didn't end up, exactly, it wasn't any random pain specialist because somehow I had a friend of a friend and all of that. I targeted within the entire space of pain medicine exactly who I wanted. I knew how to incentivize them. I knew how to entice them. And that led to us much more recognized because we had the best. We had all the KOLs inside our company. And I'm not sure that if you show up as an MBBS, and even though you create your first company, the first consultant you're going to hire is going to be the president of your society.
I mean, that is a pretty baller move, as the kids say. That's really impressive. We'll touch upon Leva Clinic in a moment. Just focusing a bit more on that transition from France to UK. So you were a consultant at the time. You did it for love. How was it transitioning from a professional standpoint? Because I imagine at the time, most of your network was in France. So then, You've since built an incredibly successful career in health tech in the UK as well. But I suppose, how did you find that transition and kind of rebuilding your network and re-establishing yourself in a completely new geography?
I was quite lost, and there was a little bit of vertigo at the beginning. I arrived here, I knew no one, I didn't understand the industry, and I realized pretty fast that the industry was much more advanced in the UK than it was in France. At the time, in the UK, there was still no health tech accelerators, but the first health tech accelerator arrived a couple of years after. There was starting to be a couple of VCs. There was like, the industry was nascent, but was starting to build in the UK. And I had realized that because of the big junior doctor strike of 2015, there has been a huge influx of junior doctor into other industries. And that had generated an entire pool of brains that the industry was rising from. Whereas in France, the number of doctors who were in non-clinical jobs was very, very, very low. And therefore, you didn't have enough momentum and to generate enough startups to have one survive or two survive. And you didn't have enough momentum to generate all the ideas and all of that. But it was because of all of that exactly as you said, it was a push factor. Many junior doctors in 2015 just left the NHS because of the negotiations around contracts, hours, pay, and all of that. A lot for good reasons, some for bad reasons. And what happened is you ended up having VCs hiring junior doctors, McKinsey and other consultancy hiring junior doctors, PE firms even hiring junior doctors to work on their health tech projects. You had engineering firms hiring junior doctors who knew how to code already. You had all of that, and that created a lingua franca. They could talk to each other in a language that they understood. They could talk about the same problems, and that created a lot of momentum within the industry. And I arrived here and I was fascinated by this bubbling, by the momentum that was generated. So I decided to do exactly what I had done 10 years ago in France and just create a community. Organized the first startup weekend in the NHS at St. Thomas, where actually a lot of people that I know today were just random junior doctors who participated in my startup weekend. They then went to events, organized events, did some talks, offered consultancy at a very low fee, and just generated momentum and then more momentum and then more momentum and then decided to just jump ship. At that point I had been a consultant for several years in the UK, and I saw an opportunity and I was like, okay, I know the industry, I know the landscape, I know the politics, I know all of that. I finally think that I'm ready to be able to do it on my own.
And then, of course, you founded your first business, which was Cellen. So exactly. Do you want to tell me a bit more about that? How did that get started?
So it was, as always, conjuncture of random events. A friend and an acquaintance, and we're talking and things happened and we're like, oh, there's been some change in the controlled drugs regulation, there's other things happening, and we're like, okay, maybe there's a play in personalized medicine that we could be doing. And we talk to people, and some people are like, oh, if you do that, I'll give you some angel money. And then you realize there's interest and momentum generated. We're like, okay, let's try to create a platform that will give the capacity to prescribers to prescribe compounded medicine so that you have a really truly personalized experience. There's more and more personalized medicine, but there is no platform that does that at scale. And we leveraged the fact that there was a change in the controlled drug regulation around medical cannabis, and we're like, this industry is going to be interested, and we can try to ride that wave at the same time as we scale the platform to be able to generate a platform that can help everyone. And so we got really close to a lot of the very nascent prescribers. We got very close to compounding pharmacies. We developed the technology. We developed a lot of aspects. It worked well. The problem is funding. And the moment you create personalized medicine, the cost of the medicine is multiplied by a factor of 5 to 20. And a lot of patients were not ready to pay a medicine that will alleviate a couple of side effects for 5 times the price that they were paying their medicine before. They'd rather switch to something completely different or try other drugs to stop the side effects and all of that. And so actually the unit economy was not very healthy. And I learned a lot. I created a team. I met a lot of investors. It was a really eye-opening experience. It was great. I had been looking from the outside into the industry as a consultant who was doing some regulatory work here, some consultancy on strategy there, being a board member here, but never being fully hands-on. And I had the chance that really the first 3 years of the company, the first 2 years and a half of the company, I was still working in the NHS. So I had a steady salary that was coming in. And I was working part-time in the NHS, and I had a lot of time to spend on the startup without being too afraid of not being able to pay my rent. And that is also, I think, a big takeaway point, is that if you build a clinical career, you can always take locum shifts, you can always do all of that. And it works both ways. One, it de-risks the health tech startup, which is a brutal scene, with a 90+% of failure at 3 years. So you de-risk the financial aspect, but you maintain the career aspect. And so as long as you maintain clinical skills, your CV to the NHS and to future employers is not tainted. On my CV, there's several years where I'm working part-time, and I ended up never leaving the NHS. Lowest, I was working half a day a week in the NHS. But I never left completely the NHS. And let's face it, like a 4-hour shift in the NHS, and therefore discussions were much easier. And I know many doctors who are doing that, who are working 1 PA, 2 PAs, and still giving their life into health tech, but they're maintaining their skills. And they're keeping their ear to the ground. There's many cases of swing in policy that I've heard through the break room at the hospital. And you're like, oh, this new report was out? Oh, I didn't realize that. And you realize that everybody's talking about it. Whereas when you're in the health tech world, you may not hear about it. Whereas you realize once you're inside the hospital that actually it's shaping conversations and care in a deep way.
I think that point about keeping your hand in clinical practice whilst pursuing, your startup adventures is a really kind of salient one, because I do think that the difference between clinicians that go into their own ventures versus, the general public starting startups is a different risk profile, because as you said, we as clinicians can always locum. Broadly there's demand for our services. So there's always that safety net. And it certainly was the case for me, when I was trying to explain my decisions to my parents, who are very risk adverse. They knew that I could always go back into training. And they also knew that I could pick up the locum shift here and there. So I would never be destitute. There would always be options for work. So I think that's, for anyone listening who is thinking about the risk is far less than other people.
Yeah. I don't have Chinese parents, but my dad had the exact same conversation. He was like,
"You're missing out."
Exactly. Do not stop completely practicing. He was very clear with me. He was like he was like, that's a silly idea, because I was in my startup. I was all in. I was like, why am I going to take this extra 4 hours a week, it's irrelevant to me now. And my dad was like, do not. And he was right. In the long term, as always, my dad was right.
So you have that experience with Cellen. You've learned a lot from it. You then go on to co-found another business, Leva Clinic.
Absolutely.
So how was that? And what did you take into it from your experiences with Cellen?
I think at the time, through the Cellen, I had looked into the medical cannabis industry and especially into the pain industry. And just for the people who are listening to you and who are not up to date on their chronic pain management skills, there is no single activity that works in chronic pain. We all know the devastation of the opioid epidemic, so we all recognize that pharmacological management alone does not work. But psychotherapy alone doesn't work, physiotherapy alone doesn't work. You have to engage the biomedical social model of care, where you at the same time provide support for the mind via psychotherapy, support for the body via physiotherapy, you provide pharmacological management, and you do social engineering around it. How do you engineer a workplace where if that person has an acute episode of pain or the background of their chronic pain, they do not suffer social consequences to it as well. And so there's training around with work, with family, with partners in life and all of that. And so only once you embrace the person as a whole and provide holistic care can you actually get into the area of 60 to 70% improvement. All of those in isolation get you 25 to 30% improvement. That's it. And so that model did not exist at scale. But you have had to have chronic pain for a decade before you finally reach a tertiary center. You would have gone to your GP, had some physiotherapy for your back pain, then gone back to your GP, had some infiltration with steroids, go back to your GP, tried opioids, do all of this before you find it, simply because the NHS is not geared up for it. And there is, I think, to this day, a 2-year waiting list for tertiary specialist centers. And no one at all had looked into how can we create a pathway which is enhanced digitally to build it at scale. And that's what we created. We created a company, private company, that had the capacity. We had tools, digital tools. We had video consultations with psychologists, physiotherapists, nurses, consultants. We had a staff of 40 clinicians at one point of all different specialties to be able to provide a true holistic care to our patients. And at the time, there was no model that did it. The pathway didn't, there was no equivalent model that existed truly holistic and that included social care, that included physiotherapy, psychotherapy, everything that I've just said. And another layer that we created is that a continuous quantifications of clinical outcome. So that we had to generate an engine of quantification using validated questionnaires on the clinician side and on the patient side, so that you could actually follow and quantify all the clinical outcomes. And that comes back to the regulatory. How did we manage to have medical device regulation? How did we manage to sell our service into the NHS? Because we had the right data generation engine behind it. And then the question of scale arrived. How do you scale something where you need psychotherapists, physiotherapists, nurses, consultant and social care in one place? You don't want to end up in a system like the NHS where people are only doing shifts and people do not have ownership and continuity of care at the center of care. So I invented the silo system, which is a pathway which was completely original at the time, is that actually we created small units and each unit was taking care of 10 to 15 patients. So one unit was composed of one nurse, one psychotherapist, one physiotherapist, and one consultant. And they were liaising with social care. And that unit had a short amount of patients, a short list, and they were dealing with those patients. And the whole idea is that you could finally mesh everything together because they always speak in MDT. So when the physiotherapist is trying to achieve a new range of motion in the shoulder of a patient with chronic pain in the shoulder because of arthritis. He can tell the consultant, well, I need you to add 2 weeks of opioids. The consultant will say, well, we know opioids don't work on that patient because she's already tried that. Because the purpose is not to treat the underlying pain. The purpose is to provide for 2 weeks exercises where I'm gaining motor function, and therefore, and at the same time, because of the effects of the opioids, you can liaise with the job of the patient and be like, oh, she's most likely to be drowsy, so she can't be driving during those 2 weeks. How do we work all of together with their occupational health to make sure that she's not driving for those 2 weeks? And so we created silos, but each silo has continuity of care and ownership. And that, beyond the holistic, beyond the engine of quantification, is to me something that was totally innovative, because that's not the way the Babylons of the world are working. That's one of the reasons why people don't think of Babylon as my GP. Babylon doesn't exist anymore. All of those discussions, a lot of the people who are listening to us will know about all of that discussion. But Babylon is just a service. Whereas we did the exact same kind of service as Babylon, but they were your doctor, your nurse, your psychologist, your physiotherapist. And that is a level of care that everybody is striving for, and almost no one does at scale in a digital setting.
So then you create this completely new model of working, and you've started this business. What then became of it?
The life cycle, so we generated data by providing care to self-pay patients at the beginning. Because of course at the time we couldn't sell to the NHS, we didn't have the validation and all of those things. Then once we have enough data, we became the chronic pain care provider for Boots and for other big companies that have a big workforce. And then we generate more data. And then finally we sold some services to the NHS. Life cycle is, as you imagine, much shorter with self-pay patient, then becomes longer with people who are coming because through a workforce improvement scheme from a company like Johnson & Johnson. And then with Boots, it's also a different life cycle. And then the NHS, it's another life cycle, and it's a much longer life cycle. And so in the same way that Tesla created a very fast, very expensive car at the beginning, and then went into mass production of cheaper cars. That's exactly what we did. At the beginning, we designed our acquisition to funnel to service patients that we know had a decision cycle that was much, much faster.
That's pretty smart. Many startups will try and sell to the NHS immediately and will die their death because of the sales cycle, and how it impacts their runway. But I think you designed that very carefully to think about the life cycles of all your kind of customer segments and then built it all up. So then, where is the business today and what is your involvement?
So we have sold the business. I'm not involved at all anymore. I left right after Series A. I had built everything I wanted. The other aspects I didn't talk about was academia. We had published many papers on our methodology, on our results and all of that, because I do believe very much that engaging in academia as a health tech startup is a way to build brand recognition and thought leadership. And a lot of companies do not spend the extra time to do that. And so at that point, I had built everything I wanted. I had created the methodology. I had won national, international grants. I had sold to the NHS. I had done all of those things. And I felt that it was time for me to move on to something else. And so I was hired as a chief strategy officer for a European company. And so I stayed on as an advisor and a board member at Leva for a couple of years. Now I'm not involved anymore at all.
Were you involved in the decision to sell?
I was at very arm's length. I was at that time. I would have made the same decision anyway. It doesn't change anything. But I was not hands-on enough to be able to make any sort of call at the time. And so I think it was what we needed to do.
And so you've done, we've gone through the journey of 2 startups now. What are you currently working on?
Currently, I am a consultant. I had a trust called the Hillingdon Hospitals Trust. I'm working full-time in the NHS, but full-time in the NHS for someone like me who does night shifts and weekends means 3.5 days a week. And that leaves me enough time to do some private practice and to have a portfolio of company that I advise. I'm working with different companies. I'm working with Imperial Bioengineering Department as their spin-out doctor. So I help them spin out their algorithms, and I'm currently working on an AI algorithm that we're going to spin out in the next 12 months. I'm working as an advisor to different company in the UK and in France. And I'm working on a new thing, which is currently the thing I'm very excited about, which is shifting the whole narrative around caesarean section. And so that is an entrepreneurship enterprise, but it's more an intrapreneurship. If some of your listeners are fluent in what that word means, is usually intrapreneurship is when you have a big company that wants the fast pace and the innovation of a startup, but within the boundaries of their company. And so that's what I'm doing within the NHS. And so the one thing that I'm doing is I'm bringing into the NHS a new caesarean section. There's currently only one caesarean section in the UK, which is the Royal College caesarean section, which is defined by the NICE guideline called caesarean birth, and which represents around 97 to 98% of all caesarean sections in the UK. But there is, across the world, 10 to 15 surgical techniques that can be applied. And at the age of personalized medicine, having a surgery that is the same for absolutely everyone does not make sense anymore. There were a lot of benefits in creating a caesarean section, or at least teaching a caesarean section that was the same for everyone, because you have economies of scale across your healthcare system. But when you design a surgical technique with the purpose of being able to be done on everyone, whether you have fibroids or not, whether you have twins or not, whether you have a cyst on the ovary or not, whether you've had endometriosis before or not, whether you've had prior surgery or not, you're not optimizing for other aspects. And if you bring together all of the different caesarean section technique that exist around the world, you can decide hand in hand with your patients to personalize their caesarean section technique and create a caesarean section that is, for example, focused on optimizing fertility. If you have a patient that has gone through IVF multiple times, they may not want to optimize for ease of the team around you. They may want to optimize for fertility, which is a trade-off, which has some trade-off with regards to other aspects of the surgery. Or you may want to do a caesarean section technique that is optimized to decrease your risk of ovarian cancer in the future. And again, if you do that because your family there's many ovarian cancers in your family, because you feel that's very important for you, there are some other trade-offs during the surgical technique. And so I'm bringing all of that together into a new pathway, which is a holistic and personalized, and I call it HOPE, which is the holistic, operative, personalized, elective caesarean section. It's the HOPE section.
So this is pretty radical, but I can see the theme in your career around personalization. I guess for people listening, and I'm personally curious myself, how on earth do you navigate this in relation to NHS trust policy, national guidance? I don't even know where to begin in terms of thinking how you get the approval to do all these procedures.
It is very difficult, I can tell you that, because it is not sanctioned by a NICE guideline or by a Royal College paper, because those are non-English caesarean section technique. You have to go through a lot of governance, a lot of regulatory, and I'm involved with the research team, I'm involved with the legal team, I'm involved with the governance team, I'm involved with the clinical efficiency group, I'm involved with a lot of different teams. So I'm in constant conversation with our service user lead, and I do conversation evenings with service users and patients. A lot of work, but it is moving the practice of cesarean section into the 21st century. And it's something that I'm very passionate about right now.
Yeah. I mean, that's really clear. We'll need to get you back on for another episode once we've seen the progress of that come through, because I think it's totally incredible. Now, we're running out of time, unfortunately. So I'm going to finish with one last question, which is, what kind of practical advice would you give to other clinicians that are thinking about pursuing these kind of alternative pathways? You've covered a lot of that through our conversation, but summarize for me. What are the key take-homes for people listening?
I will talk about the fact that you need to look into regulatory pathways, into funding pathways, way more than you think you should. You hear people saying, oh, all of that regulation is just creating so much friction to innovation. I actually don't believe that's the case. I think all of that regulation and all of those requirements are protecting patients. But I think if you don't embrace it, you're in the wrong industry. I think that's one point. The other aspect is, because in the UK, healthcare is almost synonymous with NHS, don't get outside of the NHS 100%. Maintain your clinical skills, maintain an ear to the ground by having always a foot inside the NHS. And the last thing that I haven't talked about earlier, which I think is really interesting, is do a pre-mortem. Don't do a post-mortem. Write down all the reasons why in 3 years you will have failed, where you will be if you have failed, and how you can prevent all of that. And on a personal level and on a company level. So on a personal level, for me, it was following the advice of my father. Continue to practice, continue to practice, continue to practice. Whatever happened, if it's successful, great. If it's not, you can always go back. Losing your license would be the worst thing that can happen to you, especially since I've trained for 17 years to become a consultant. But that was the one thing. And same thing on the other side. Look about all of the reasons why you can't succeed in that industry. Maybe you didn't have the right regulatory support. There was policy decisions that were made that impacted your funding and the willingness of the NHS to spend money, and work on that pre-mortem so that you are foolproof. You are protected yourself and your company is protected for the long term.
Oh, that's fantastic advice. So that's all the time we have for today. Thank you for joining me, Ben. I'd also like to say as well that for those who are only listening, Ben has shown incredible professionalism as my mum has walked through this this recording on multiple occasions, and also the sun has slowly set as we've recorded. So he's basically talking to someone in the Blair Witch Project. So through all of this, you have not broken a sweat. So I commend you, Dr. Benjamin.
It really was a pleasure, and really I'm looking forward to many more conversations with you.
Brilliant. So for all those who are listening, if you like what you hear and want to support the show, do like and subscribe to us on Apple Podcasts, Spotify, YouTube, or whatever podcast platform you're currently listening to. It would mean a lot to me, and it would help us spread the message to others exploring alternative paths. Thanks for joining, and see you next time. Bye-bye.